I'm going to start recording and just say welcome, everyone. I'm just delighted to see so many people joining, and I thank Dr. Lynn for inviting you and keeping me going on this. We
Yeah,
have a couple of quite interesting cases that are common enough that usually you will see these in your practice at
yeah.
some point. So, Dr. Lin, why don't you go ahead and do the case presentation of the retroperitoneal case?
Yes, okay. Anh Minh Sen. Ờ, em sẽ trình bày ca này bằng tiếng Việt cho mọi người dễ hiểu. Sau đó rồi xin ý kiến của giáo sư một số cái comment sau đấy. Thì cái trường hợp bệnh nhân, mọi người nhìn thấy slide của em chưa ạ? Mọi người đã nhìn thấy slide chưa ạ?
Thấy được.
À, Đây, bệnh nhân nữ 54 tuổi, vị trí lấy bệnh phẩm là u xơ phúc mạc. Cái chuẩn đoán lâm sàng là theo dõi cái u cơ mỡ mạch ở thận. Cái trường hợp này thì là bệnh nhân từ nơi khác, bệnh viện khác chuyển đến viện 103 để nhờ hội chẩn và nhuộm pháo mô miễn dịch. Nên là cái tiền sử của bệnh nhân cũng như là kích thước của khối u mình không không tìm hiểu được. Họ chỉ có một cái giấy ra viện thì ghi là chẩn đoán là cái u tế bào thịt thoi, cần phải nhuộm pháo mô miễn dịch. Thì trong trường hợp này thì đây là cái tổn thương của khối u. Ừ, kích thước của khối u mình cũng không nắm được, tại vì là họ chỉ gửi tiêu bản khối nến thôi, nhìn trên các có 4 lát tất cả thì khối u tương đối là to đấy. Thì thấy rằng là cái tổn thương u này không phải lấy ở vùng thận, vì xem tất cả các lát đều không thấy nhu mô thận ở đâu cả. Cái thứ hai nữa là mình thấy ờ, thấy rằng là cái tổn thương chính của nó là cái mô liên kết xơ mỡ, trong đấy có phần tổ chức u đây. Hai bên này là vùng u. Thế tổn thương u thì nhìn vật kính lớn hơn thì thấy rằng các tế bào có thể là hình thoi hoặc là những cái tế bào hình tròn. Nếu mật độ tế bào là khá là nhiều, nhân thì tương đối không điển hình, nghĩa là nhân có không không phải là bất thường quá, nó là khá là đồng dạng. Các cái mạch máu thì không phải là không không rõ của cái mạch máu hình chân chim. Nó không chưa nhánh, thế là thì những cái mạch máu nó đơn giản hơn. Thì trong trường hợp này nhìn kỹ hơn nữa thì thấy rằng là trong bản thân cái vùng đặc đấy có những cái tế bào mỡ trưởng thành. Đây là những cái tế bào dạng mỡ trưởng thành, và có những cái vùng thì có hơi có tế bào, thế mật độ tế bào ít hơn, tế bào nhỏ hơn, và nền có nền nhầy nhẹ. Thì trong trường hợp này nhìn kỹ hơn nữa thì có những cái tế bào mỡ kích thước nhỏ hơn, ờ,
Qua đây.
nhỏ hơn, và không thấy các nguyên bào mỡ đâu cả. Và khi nhuộm với khi 67 thì tỷ lệ nhân chia khá là cao, tầm 20 đến 30%. Đây có vùng nhân chia rất là cao luôn. Ờ, Tiếp theo thì mới đầu ấy thì là nhuộm nhuộm với các dấu ấn luôn, để mình nói đấy là của loại trừ của các cái trường hợp như là sarcom của thần thần kinh và sợi thần kinh là S100 âm tính. Mức 4 thì là cái sarcom xơ nhầy là nhầy xơ độ thấp thì cũng âm tính. CD34 thì trong trường hợp này có dương tính ổ. Và nhuộm tiếp với hai cái dấu ấn mà nghĩ đến sắc côn mỡ thì đó là cái CDK4 và MDM2 đều dương tính. Thì trong trường hợp này thì cái ca này xem kỹ lại thì thấy kiểu hình mô bệnh học cũng như là hóa mô miễn dịch thì nó phù hợp với một cái sắc côn mỡ không biệt hóa, mất biệt hóa. Thì tất nhiên là cũng chuẩn đoán phân biệt với cái sarcom xơ nhầy độ thấp, mình trong đó thì đã ngược cái mức 4 tính rồi. Và nếu mà sarcom xơ nhầy độ thấp thì nó sẽ không tương tính với MDM2 với cả CDK4. Nên là ở cái trường hợp này nghĩ nhiều đến cái ung thư sarcom mỡ mất biến hóa. Yes, Professor.
So yes, I think this is an interesting differential that you put here. But in reality, low-grade fibromyxoid sarcoma is not a tumor that we usually see in the retroperitoneum. So, on the basis of location, certainly dedifferentiated liposarcoma is far more prevalent. And of course, your negative staining with MUC4 confirms that it's not low-grade fibromyxoid sarcoma. Um, I'll just make a couple other comments and maybe highlight some of the features that I think are very helpful for this. Pulling up the digital slide that you sent me as well. Um, because obviously you've got sort of the component that attracts all the attention is this very blue cellular and slightly myxoid area that has all of the mitotic activity, as you saw in this little focus here, and the somewhat myxoid change. But I'd like to call attention in this situation to the surrounding tissue, which I think is equally helpful. So the low cellularity F areas can really help you to confirm the diagnosis of a dedifferentiating process. So if you look at this fatty tissue and specifically these fibrous septi here, you'll notice that even at this intermediate power, you can see several quite atypical cells in this infiltrate. They don't look like lipoblasts or even like lipocytes, but these are the malignant cells in this process. Now, you will occasionally see some of those slightly atypical cells within the fat of this process as well, but the easiest place to find them is in the fibrous septi between the fatty tissue. And so if you find that feature in the setting of a retroperitoneal fatty tumor, that is pathognomonic of a low-grade liposarcoma in this location. And so then when you have this low-grade component and you see this high-grade component with variable morphology, then it's pretty easy to say this is a dedifferentiated liposarcoma because you have both the low-grade and the high-grade elements. Things that can make this distinction hard are if you have a very dominant myxoid change, you might even begin to think about myxoid liposarcoma. But again, like the low-grade fibromyxoid sarcoma, myxoid liposarcoma just does not occur in the retroperitoneum. I don't know why, but it doesn't. And so even if you have a very myxoid component to this tumor, in the setting of any sort of lower grade lesion, it's more likely to be a dedifferentiated liposarcoma with some areas of myxoid degeneration. So those are, I think, the key features. Now, if you don't have an MDM2 stain, and maybe you don't have a CDK4 stain, there is another stain that you probably do have in your menu and can do, which is not specific, but in this context is quite supportive of the diagnosis of liposarcoma, and that is the P16 stain. P16 is, as you know, it's positive in all the HPV-related tumors, but it's positive because the E6 molecule gets turned on in these cells due to various other etiologies. And there are other tumors that can do that. And so many times when I didn't have immediate access to an MDM2, either immunostain or FISH test, I would do a P16, maybe a CDK4 if we had that on our menu, And based on that being positive or otherwise, I would begin to help them make plans or propose the fish testing or something like that. So that is just another little helpful clue with regard to this tumor. The other thing to be aware of in this tumor is that the dedifferentiated component can be either high grade or lower grade. And so it can actually look like strands of smooth muscle, admixed cartilage, heterologous type of tissues, and just a solid fibrous tissue in the background. That would be a kind of lower grade dedifferentiation, if you will. And it will still have the MDM2 marker, uh, but it may not have the very high grade appearance. The other thing that I think is interesting from a historical standpoint is that in a number of circumstances, when they took retroperitoneal tumors that had previously been called undifferentiated pleomorphic sarcoma and did the MDM2 fish testing, that a large portion of those tumors ended up being positive with that MDM2 fish. And that, I think, underscores the fact that this tumor, it can totally obliterate the well-differentiated component. You know, you can just overgrow this, and you'll just be left with a very high-grade, ugly-looking sarcoma that you really can't distinguish or otherwise tell unless you have this molecular signature of MDM2 positivity giving you the clue. And that is, as you've seen, retained in the dedifferentiated component. So it's helpful in those circumstances as well. And finally, the immunostain is a good marker, but there are some false negatives where you may have presence of the rearrangement with MDM2 or a circular chromosome or other molecular marker, but for whatever reason, you may not have expression of the protein that we identify with the immunostain. And so if you've got good morphology that suggests a dedifferentiated liposarcoma, but your MDM2 stain is negative, well, I would still keep dedifferentiated liposarcoma on your differential diagnosis because it can be, the immunostain is not totally sensitive. It's fairly specific if it's present, but it's not totally sensitive to all of the possible molecular alterations that you can get to that gene. Questions or comments about that?
Thank you. Is P16 is useful to diagnose?
Yes, I think it can be useful. If you have MDM2 and you're thinking, I would not bother with P16. But if you don't have it on your menu and it's going to take you a while to get it, then you can do the P16 stain and get a good inclination that it's likely going to be positive. They can begin with treatment planning while you get the confirmatory fish test or immunostain from your companion, colleague, laboratory, or wherever you may want to send that.
Yeah, thank you.
So, Dr. Han, are you here?
Yeah, Professor Hassan.
Oh,
Sorry
wonderful.
for my late.
Oh, no, no problem. No problem. I thought that was you, but I just wanted to be sure. So, would you like to present your two cases? I think both of those cases are instructive.
Yes, yeah. So now I will represent my cases.
Yes.
Yeah.
And feel free to give the history in Vietnamese. That's fine.
Yes, I will speak in English.
Okay.
Yeah. So
You can share your screen if you have it, or if you'd like me to share it, I can also bring them up.
um, could you please share your screens because yeah, it's not convenient for me to share now.
Okay, well then
Okay.
let me do that.
Thank you.
Um,
Mm,
your case is so here's the first
yeah.
case here.
Yeah. Please, please let me share. Please let me say now I write the
Oh, you
case.
want to share now? Okay, I'll
Yes.
stop.
Mm, Um, um, here. So now I'm so share. I will share one screen. Here. I'm sorry. Here. This is my case. The first case is of a woman. She's 30 years old, and she has a mass in the left breast. The tumor was measured approximately 1.5 um, centimeters, and um, on the microscopic, I saw I don't know my I don't know this of the breast tissues, and I saw the uh, atypical hyperplasia of the epithelial cells, and uh, we suggest the immunohistochemical stains to differentiate if it is a ADH or DCIS, because we see abnormal proliferation of the epithelial cells, especially in the peripheral, we see that the epithelial component, and hardly can see the male epithelial cells, and we did let me see we did PR. It's the high percent high proliferate high proliferate rate, and P60 uh, and the second, I'm sorry, the arrangement of the picture is not in order as my thoughts, so I will took the ER. ER had also the high proliferation rate with and the intensity. The HER2 is about some areas have two positive, two plus intensity. It's moderate to a moderate complex um, cell body cell standing, and especially we tried the staining of the CK56 P CK56 here. We see the uh, peripheral staining of the cells that we such as it could be the epithelial cells, but some in some areas uh, we can see it's it's positive in the cells within the lumens, while others markers, for example, P63, which only are positive around the ductals and negative in the lumen. They also with the CD10. CD10s are also positive in the peripheral of the lumen, not in the ductal. So my question to for the Professor Hassel was that could you please differentiate it for me? Could it if it is a IDS or DCIS? Because in this circumstance, we can see the quite unusual stain of the CK56 because in my thoughts I want it is positive only at the peripheral of the lumen, not in the cells not in the cells of the um, uh, in the lumen. I mean, so yes. So Professor has give has given me the answers. So the professor, could you please explain to us again what did you diagnose this? It is DSIS, not a ADH. Thank you, Professor.
Okay, so thank you. Let me share the slides from my end, and I can
Yes,
drive some of the remarks as well.
yes,
Um,
thank you.
so first of all, we still rely very heavily on morphology, and so the architecture here is very busy and complicated, but we clearly have some areas where we have quite a cribriform type pattern, as you see here in several adjacent ducts. And as you look at these cells, there is a degree of nuclear pleomorphism, but also monomorphism. It's sort of an odd thing to say, but they're atypical in much the same way to each other. And of course, in low-grade ductal carcinomas, as opposed to ADH, you have this uniformity, this clonality that we see in the hormone receptors expression, but also to a degree here in the nuclear features. And this is, I think, one of those helpful markers. So when you can point to ducts like this that clearly have the morphologic features of carcinoma in situ, then that's very helpful, especially if then your other markers tend to coincide with that. Now, you have other areas here where you've got this sort of sclerosing change, and in some of these areas, your spaces are of irregular contours, as you've pointed out. In my evaluation and in my colleagues' evaluation of these kinds of lesions, the stains that are most useful in determining or differentiating atypical hyperplasia from ductal carcinoma in situ are the estrogen progesterone stain and the CK56. So those two stains have contrasting patterns, and I think our case shows some of both of those. Let me see if this is, oh, that's the P63. I got to keep looking at which stains are which here, so make sure that I'm showing you the right. Okay, so here's the ER stain. And let's go to the areas that we were looking at just recently, which I believe were these areas. Well, we're a little deeper cut, but there are these kinds of areas where we have this cribriform, strongly staining pattern. Now, notice that we have other areas adjacent here, like these over here, that are the more sclerosing pattern that are not positive, that don't have that strong staining pattern. So, we sort of have two different types of reactivities going on here. One is this that's forming the more cribriform patterns, and then the other is a little bit different with more variable staining, as you see in some of these areas here. So we've got a mixture of the proliferation going on. As we know, ductal carcinoma in situ can grow into other pre-existing lesions like lobular carcinoma in situ or sclerosing adenosis or other lesions. But we have here a predominant pattern of this clonal staining. Now, I believe this is the CK56. Is this right? Let me see. No, that's her too. That's the CD10. Where's my CK56? Is it here? No. Which one haven't I shown here? That's PR, which is the same as ER. Okay, here's the CK56. So as you described, we see a lot of this, but notice that it's more in these sclerosing areas like this. And of course, CK56 will stain the myoepithelial cells, so it will surround all of the ductal areas, but then it's interspersed within the luminal proliferation. And that is a marker of benignity of atypical hyperplasia or other hyperplasia. But then, as you pointed out, we have broad areas where we don't have any luminal staining. And let's just sort of make sure that those sort of correspond to what we were seeing as the cribriform area. So I'll go back out to low power here. So here's an area like that. And then we have a little bit more of that down here in this area here. And then some of these ducts over here. So it's a little bit mixed up with some of that other stuff. We don't have that really nice cribriform pattern in this piece. Well, maybe we do up here. Okay, so we do up here. Here we can see that it's just in the peripheral and the stromal cells that are staining. It's not in the luminal cells. So given those findings, I mean, this is not the best example of CK56 in DCIS because it's so mixed up with the sclerosing lesion here. But to my eye, it was enough to treat this as a DCIS, given the morphology and given the very clonal ER and PR staining. And as you showed very nicely, the P63 was um, present throughout, along with the CK56, so confirming that everything is in situ. So this is I just have our experience. We don't on ductal carcinomas in situ. We don't usually do CD10. We don't usually do HER2. When we're in this differential, we would do ERPR and the CK56 and probably P63. But beyond that, in terms of answering that question, is it in situ carcinoma? Is it atypical hyperplasia or invasive carcinoma? Those are the stains that we put most of our weight on. I can see some value in the CD10, but we don't usually do that in our laboratory. So I didn't have any experience to interpret that one. Do you want to show the other case, Dr. Hunt? Because it's also very similar to
Yes.
this. Yeah.
Um, oh, so, how can I share my screen? I share here. I'm sorry. Yeah. My second case is had the same present for the first case, but it is on the biopsy specimens, and the patient was 41 years old. So, but in this case, I have to much careful about the diagnosis because it will affect the to the treatment of the patient, the lesion here, and in this in this case, the main circumscribe is the papillary intraductal papilloma, and in this in the ducts, the papillae has the free point, which it does have the anastomosing appearance in the um, uh, typical hyperplasia of the papilloma. So I could raise um, if it is IDH in the papilloma or DCIS, and I did the IHC for this patient, and I also see the P63 positive around the lumens, and with the papillae, the stock of the papillae was negative for the P63, and the HER2 it has a moderate to low intensity for the cell for the cells borders, and this is K67. It has a low proliferative rate. It's about I think in this case about 10 to 15 percent, and this case with the ER, it has intense and intensity it was high, and the rate was high too. With the CD10, it's also now positive in the boundary of the lumen, and the CK56 is nice, very nice to define it in the border of the lumen. Not it doesn't go to into the papilla inside. So my question to the professor also, could it be the ADS or in on the introductory papilloma or BCIS? Um, because it has only this foci on the biopsy. Yes, my question.
Yeah, that's a great question. It's a small lesion, but you do have multiple separate areas, and there's actually one other area up towards the top of that slide, right there at the end of that,
Yes,
which is also the same proliferation
yes,
and has the same staining characteristics. And this has a more cribriform area and also had microcalcifications. So I agree. I was concerned. This is a very small lesion. What are we going to do here? But I think given that we have the second area and we have multiple ducts that all have a similar appearance, even though it seems to be a small lesion on this biopsy, clinically it may be bigger. We don't know where it was, what other findings they saw, where the needle passed relative to the lesion. It's possible also that, and this happens sometimes, that the needle biopsy will remove it all. You'll come back with a lumpectomy or a mastectomy specimen later on, even if they have a marker in the tissue, and you won't see anything more of this. That's a very real possibility, but it's not one that you can make decisions on at this point. It's because you don't have margins, and you do have the clonal pattern of the hormone receptors, the absence of CK5/6 in any of the luminal spaces. And you again have the H&E features architecturally to say there's a degree of nuclear atypia. You've got the architectural atypia of this focal cribriform and papillary architecture, the microcalcifications, and a little bit of nuclear atypia. So it does fit all the functions. Your immunohistochemistry agrees with the microscopy, and obviously they biopsied this because of the concern probably about the microcalcifications. So it passes what we used to call the triple test. The clinical, the morphologic, and the immunohistochemical all support the diagnosis of ductal carcinoma in situ. So yes, she's very young,
yes, the
but
patient.
yeah, but that that doesn't get us off the hook. We shouldn't. We should actually be much more careful, of course, in young patients because it does have longer follow-up implications. But cancers do happen in younger patients, and they're happening in younger patients as in increasing numbers with not just breast cancer, but other cancers as well. So because of that, we're screening at younger ages. Now, when I was a young trainee or a young pathologist, we didn't even start doing mammograms until their mid 40s. And now you have some people getting them in their 30s and so forth and finding things. That's it's a very effective screening mechanisms, but we do have to be aware that it can happen in younger patients. So I reviewed it and I think this is DCIS. I showed it to
Yes,
one of my colleagues at the Cleveland Clinic, who
yes,
also said she thought it was. And of course, she was also interested in my experienced opinion, but I think someone who's working with this in volumes day to day gets fairly comfortable with this diagnosis. Um, Needle core biopsies do require, good, careful attention, making sure that you've correlated what the radiographic findings were. Sometimes we will do radiographs of the specimen to make sure that we have sampled the concerning areas. If, for example, they're concerned about microcalcifications and we don't see microcalcifications in our sample, then we usually will do a specimen radiograph or a radiograph of the paraffin block to make sure that we have got the microcalcifications in the sample. And if we see them in the block still, and we haven't seen them on the slide, then we will take deeper level sections through that block to make sure that our findings fit with the radiographic findings. It is helpful to correlate those two things together. And so in our breast conferences, we always have the breast radiologist there who can comment on what they saw on the radiographs, the ultrasound, or otherwise, and what we saw on the microscopic findings to make sure that there's a match. That's the real critical thing, because you don't want to leave the answer either in the patient or in the paraffin block. So if you sure that the radiologist had the lesion, they may, if it's calcification oriented, they may radiograph the specimen grossly to see if they got the calcifications. And then we need to do the same thing if we don't see them on the slide. Now, in this case, they were there. So, we can be reasonably assured that we were probably looking at the same lesion that the breast radiologist was commenting on and trying to biopsy. So this is an important area for very tight communication with your colleagues in radiology.
Professor Hasso, I looked for the literature and and on the textbooks, this is that if we see the two separate tubular lobular units, it could class certified for DCIS. So in this in my case, it is here. The number one here is the one separate lobular tubular lobular unit, and this is the second lobular unit. It is satisfy the criteria for the diagnosis of DCIS.
Yes, it does.
Because I actually in my hospitals, with the small lesions, people often hesitate to diagnose it as DCIS because it can affect much. We usually have controversy about this type
Yeah.
of tiny lesion. So yeah.
I can understand that. The size does make a difference. I mean, you have this one on the right. This is several millimeters in size, and so I would not say that's just a single tubuloductal or ductolobular unit because of it's just so much bigger than a single ductolobular unit would be. The one on the left, that is a little closer to what you expect for a single ductulobular group. The second issue has to do with how do your surgeons manage the diagnosis of atypical ductal hyperplasia as opposed to ductal carcinoma in situ. In our institution, the management is very similar. So if I say something is atypical ductal hyperplasia and they have an identifiable mass lesion, then they will excise that, either because of the risk being there or just reducing the need for follow-up. And pretty much the same answer with ductal carcinoma in situ. They're not going to do radical surgery for ductal carcinoma in situ if it's just a localized lesion with a few calcifications. If, on the other hand, they have, you call it ductal carcinoma in situ, and they have multiple sites with microcalcifications, well, that, in the ironic sense, sometimes ductal carcinoma in situ can result in more radical surgery than even invasive cancer, because it can be more widespread. Um,
Mm.
Although, it's ironic that it's non-invasive disease, and sometimes they get a full mastectomy instead of just a lumpectomy. Whereas for, grade one uh, invasive carcinoma, they're going to do a limited lumpectomy, and maybe you'll look at the lymph nodes or something, but they're not going to do a full mastectomy. So you need to sort of be sure that you're comfortable with what further steps your diagnosis is going to lead to. Um, and if it's not going to lead to re-excision, and you're calling it, when you call it atypical ductal hyperplasia, then I think you may have to be be very careful about having a very conservative line for that diagnosis, because I think you could potentially be setting yourself up for unfortunate recurrences with either more DCIS or potentially even invasive carcinoma down the road. Now, obviously, the follow-up time between when you have a DCIS like this and when you get invasive carcinoma can be literally decades. So you may be gone and other people may, but the patient's still going to have that. So
Mm.
um, I uh, I think you just need to be very sure that you're coordinating well with your surgeons and your radiologists as you make this diagnosis, um, to make sure that the that you understand their next steps and can help to make the decision appropriately based on what you see. It's never easy. It's never easy to say, to a young woman, well, you have DCIS,
Mm.
you're at risk for an invasive carcinoma. But
Mm.
it's certainly much better to say to a young woman, you have a risk lesion, than to say to a 52-year-old, well, you have an invasive cancer now that's spread to your lymph nodes. I don't want to have that conversation. So I'd much rather catch it at DCIS 10
Mm.
years earlier than to have to worry about it later on.
Yeah. Thank you. Thank you, Professor.
And but your comment about other people having different thresholds, and that this is an area where reproducibility between observers can be different. And so you shown
Mm.
it to me, and I was saying, well, I can see how you could be concerned. Is this enough for DCIS? And so that's why I showed it to Dr. Yoon at Cleveland Clinic. What do you
Mm.
think about this? And she said, yeah,
Mm.
that's where I would call it too, and so forth. And so, now I've got a little bit of consensus, I guess, building, um, that of people I trust and people who have experience to help me make sort of titrate or adjust my threshold for what I call cancer or what I call hyperplasia. And we're always doing that, and we have to do that very often, very regularly, through sessions like this and through other interchanges, so that we can be as reproducible and as uniform between institutions and so forth as possible. Uh, there's a lot of art and subjectivity to pathology, but we need to strive for uniform agreement and uniform interpretation of the criteria, the published criteria, and so forth. So that's why we have medical literature. That's why we have tumor boards. That's why we have case conferences like this, so that we can continue to adjust our threshold, our diagnostic criteria to what our colleagues or others are saying. I tell our residents, pathology is a team sport. You need to have good defenses. You need to have good goalkeepers. You need to have everybody who knows their role and knows how to play their position and can help you when you need to play in their position or need to play in their field. So, since I don't sign out breast every day, I want to show it to someone who does. Uh, I don't sign out, retroperitoneal tumors every day. Let's show it to someone who sees a lot of these. Those are all good practices and a very important part of being a pathologist. So
Yes.
that's my little lecture and rant for today.
Thank you, Professor.
Well, thank you, everyone. This has been a great session, and I appreciate you bringing your cases forward and sharing your concepts and ideas with us.
Yeah.
Um, and I look forward to these, and I hope that you do. I'll publish or post the recording later, probably early tomorrow, and we will see you again soon next month.
Yes,
Yeah.
Professor.
Thank you. Good night, Professor.
All right. Bye
Okay.
bye. Have a good holiday,
Bye.
everyone.
Thank
Yes.
you, Professor.